Good morning. I'm Professor Rob George, and I'm Medical Director at St Christopher's Hospice in London. I've been asked to talk to you about medical eligibility criteria, and it's a great privilege to do so. Now, this is a very tangled area, actually. Obviously, you're addressing the very heavy burden of whether or not to legalise assisted suicide and euthanasia. But there's a second question that's linked to that, and it's who should do it. Now, this is assumed to be doctors, but in fact, that's the worst possible option, in my opinion. You've asked me to speak about 4 possible areas of relevance. First is what we mean by dying, comments on pain and suffering, mental states, and some comments about discrimination and vulnerabilities. So what do we mean by dying? Well, diagnostically, we're actually not that good. And about 1 in 20 postmortems end up showing that somebody was treated for the wrong condition. And certainly I and my colleagues in palliative care see people every year referred to us as dying, who in fact turn out not to be and may even be curable. When it comes to prognosis, this is pure guesswork, of course. I'm reasonable at looking at days to weeks in terms of prediction. I'm pretty hopeless when it comes to months. And interestingly, Oregon have slipped by this one by saying in their legislation a prognosis of 6 months without treatment is the interpretation they put on prognosis. And of course, that's almost a catch-all. So it would incorporate, for example, young people who had insulin-dependent diabetes, because if they stop their insulin, then they will die in weeks or possibly months. Pain and suffering, of course, is entirely subjective. It's about biography, it's not about biology. And most of us would say, and certainly in palliative care, we say pain and suffering is what somebody says it is. And you can see a quotation there by D.H. Lawrence from his poem called Healing. When it comes to unbearability, and some legislatures do have unbearable suffering in their criteria, then of course it's the doctor who decides and not the patient, because that is the job the doctor has, and that in itself is discriminatory, particularly because there have been occasions in the Netherlands, for example, where doctors have refused to end a life because they don't believe the person is suffering sufficiently. Mental states are also tricky. Legislation will incorporate within it comments about mental capacity, that's the ability to think and come to judgments, and mental illness and disorder, in other words, psychiatric conditions and things such as depression. And a significant percentage of people who ask for or put themselves forward for assisted suicide or euthanasia have significant depression. And this often as not is missed, or indeed it is considered to be a legitimate reason for somebody wanting to have their life ended. And this leads us on to the third area, which is called demoralization syndrome. And that is people who, because of experience, because of existential crisis and all sorts of other things, have a catastrophic view of their future, or they've been so misled or fearful of the disease or diagnosis that they have, that they worry about an appalling death, when in fact the evidence suggests that that's not going to be a problem. The classic example is motor neurone disease with dying of suffocation or drowning, which hardly ever occurs if it's managed properly, and yet people continue to believe it. When it comes to discrimination and best interests, if assistance to die is allowed for one person, why not any person? And doctors actually respond to their patients very much in this kind of way. So when questions such as, why do you get this because you're dying, but I can't because I'm not? Or what makes your pain and suffering worse than mine? Or is my mental suffering not just as real and unbearable as your cancer pain? Or if I dement, I will already be dead to who I was, so why keep me alive? When doctors are confronted with these kinds of statements, then they find it very difficult not to act in somebody's best interests and stretch rules, or in fact, frankly, ignore them. And inevitably, this leads to changes in restrictions, and every legislature has shown that the restrictions are really unsustainable for significant periods of time. So drawing things together, those are my initial questions on the left-hand side. What do I conclude about them? Well, I think the complexity of dying and mental ill health evades meaningful legal definition. I think that doctors, and it's my experience certainly, that doctors default to a blend of their patients' best interests and their own views of best interest, and they can be vulnerable, for example, to demoralization as well. And they are too open to error and abuse. And there's a large literature demonstrating this, actually. And then thirdly, narrow and generalized restrictions, excuse me, will produce unsustainable discrimination. And I don't think that can bear up under the scrutiny of modern society. So we're left really with stark realities if we're confronting this question in this way. And my reading of the evidence is that medical criteria cannot work safely. And you're left therefore with a very unpleasant binary choice of what is worse, not to kill people who want to die, in other words, for things to stay as they are, or to end up killing people or ending their lives when they may actually have wanted to live, had their depression, had their demoralization, and so on been managed properly. So I've put my concerns there on the left-hand side. Is there an alternative? Well, I think there may be, and that's not for me to say, but I'm going to put it forward. I think we should uncouple lethal solutions from healthcare altogether. I think we should individualize cases through a judicial system and not a medical process, because everybody has the case to make for themselves. That there's a separate system of practitioners directly accountable to the courts, doesn't involve medicine, it's hermetically sealed, and that you can find doctors and nurses to what they do best, and that's to care. And then finally, of course, we must secure adequate specialist palliative care provision to deal with the issues of pain and suffering, and mental health services that will support them and work alongside them to look after people who are facing death with fear, suffering, and concerns. Thank you.